true vertical release incision. And the first new is that this vertical release incision should be not extended too much in alveolar mucosa. Only when, for the first time, you see a different quality of the bleeding, because you get to the submucosal tissue and the bleeding, from a bleeding line, it becomes a drop. You don't have to go further apical. Now, this area, which is limited by the horizontal incision, an imaginary line that is connecting the soft tissue margin with the true vertical release incision, describe the area of the surgical papilla that must be elevated. Split thickness means with the right uniform thickness made of epithelium and connective tissue. And you have to be very careful in order to keep each angle of this trapezoidal shaped papilla with its intact shape and thickness, because it is critical for the blood supply when this papilla will be moved cornal to cover the anatomic desepithelialized papilla. Now, you take a periosteum elevator, and for a very, very small area in the middle of the flap, you make the full thickness elevation of the flap. Now it starts a new incision, which is called deep incision, very limited in apical direction, and it's only used to separate the muscles of the alveolar mucosa from the periosteum. And you don't need to extend this incision in apical direction, but once the alveolar mucosa is free to be detached from the periosteum, you just have to change the inclination of the blade and go superficial. And it is this second incision, the superficial one, which is made with the blade parallel to the alveolar mucosa, and it's used to remove the old muscles from the inner aspect of the alveolar mucosa that is critical for the advancement of the flap. Then you have to perform root planing, which is critical in order to expose dentin good enough with dentin tubuli, which expose collagen fibrils for the adhesion of the blood clot. In order to improve blood clot adhesion, we need to remove the smear layer from the dentin tubuli, so we apply ADTA gel 24% for 2 minutes on the root surface. When the root is very buccally displaced, and so there is a large area of the root to be covered, we need also to adjunct amelogenins in order to improve the quality of the attachment and achieve as much as possible new cementum formation with new connective tissue fibers inserted on it. Now there is the desepithelization. The desepithelization is done with the blade at the base in order to prepare a connective tissue surface that can be followed by a microsurgical scissors. That is the only instrument that once the base is desepithelized, and you see that the assistant with the suction keep the epithelium turned up, so now you can follow the connective tissue surface until the tip of the papilla is reached with the thinnest instrument we have in our microsurgical kit, that is the micro scissors. Now, even if the exposure of the bone is more than 10 millimeters, the only area where we need a barrier, because in this case there was almost no keratinized tissue coming from the palate, no keratinized tissue at the buccal aspect, we have to improve the marginal area at the level of the cementoenamel junction with the connective tissue barrier. This barrier is called connective tissue graft. Which kind of connective tissue graft we use today? It's extremely thin, free gingival graft taken at the level of the palate, so superficial that you see it does not bleed almost during the surgical procedure. And it is critical that during the removal of the graft, you don't make the apical incision first, which will be made after in order to connect the two vertical release incision. Now, exactly in the same way, you open the split thickness papilla at the buccal aspect, you open the angle mesial and distal along the two vertical releasing incision in order to keep your blade parallel to the soft tissue and give exactly the same thickness to the connective tissue of the palate. How much height do you need? 4 millimeters. It doesn't matter if the recession is 10. We only use the connective tissue graft where it is critical, which is at the level of the cement enamel junction, to prevent the flap shrink and collapse. Only at this time you connect the most apical extension of the vertical releasing incision and you remove the graft. And this procedure lasts about 4 to 5 minutes. That's all. It does not bleed at all. It's completely painless because you remain very, very superficial. Now, during the time it takes for you to remove the fatty and glandular tissue of the palate that you don't need at all, and in order to make the desepithelialization, which is done extra-orally with your blade, the patient is resting. And this is critical in order to make the patient believe in this procedure very, very not stressful. The patient leave this procedure as you have never been in the palate because we have already been in the palate for 5 to 2 minutes. And now the patient has time to rest, during which you are going to prepare accordingly your connective tissue graft coming from the desepithelialization of the free gingival graft. The desepithelialization is done horizontally with the blade, and in the most coronal aspect, that is where the graft was facing teeth, where the piece of soft tissue was still in the palate, you have also to make this, which is called vertical desepithelialization. So a small area in the most coronal aspect of the graft must be removed vertically, because this is an area that very frequently some epithelium can remain. Now you have only your strip. So you know, I'm treating a 10 millimeter gingival recession with a 4 millimeters height of connective tissue graft taken from the palate, and this is really minimally invasive surgery. Now this graft is sutured at the base of the anatomic desepithelialized papillae with the use of very, very small suture. It's a specific type of suture which is called PGA. It's a 7 millimeter long needle, so very, very short needle with very, very thin suture. It's a 7-0 resorbable suture. And this allows you to achieve a very, very nice adaptation of your graft despite the root is very buccally displaced. Sometimes when the root is so outside of the bone housing, you need 2 small sutures for each papilla in order to make the connective tissue graft follow perfectly what is the buccally prominence of the root. If you don't achieve a very good adaptation of the graft to the root, the graft moves and shrinks. And when I speak about good adaptation, the next pictures will tell you what I mean. It means that the graft should be really well, perfectly adapted, both at the level of the papilla area, but also at the level of the root, and only in the marginal area, where it works as a barrier, as a wall to protect the keratinized tissue of the flap to shrink in apical direction. Then, a general rule which must be always respect is that the vertical releasing incision should be closed first. And since you did not extend the vertical releasing incision in alveolar mucosa, you can connect the alveolar mucosa of your flap with the adjacent soft tissue that, being attached gingiva, you don't need to make any periosteal anchorage. And this is a great advantage because you can mask with scar formation the vertical releasing incision. Once the vertical releasing incisions are completely closed, you have to change the type of suture and use the so-called slit suture, which is made of a perforation of the surgical, anatomical and palatal aspect of the papilla, only from the buccal to the palatal aspect, neither the opposite. So when you go from the palatal to the buccal aspect, you just pass the needle below the contact point, then you go back to the starting point, And when you pull this suture, since the suture is anchored twice below the palatal aspect of the tooth, you have a very good cord effect that make your soft tissue marginal very, very well adapted to the convexity of the enamel in a more corner position with respect to the positioning of the graft. So the flap is positioned corner with respect to the graft, and it is well adapted to the convexity of the clinical crown so that there is no space for the blood to get out. This is the concept I would like to share with you. Wound stability. What does wound stability mean? It means that at the end of the surgery there is no way for the blood to get out, and if there is no way for the blood to get out, the blood will accumulate, will stabilize, will become blood clot, and you will have a good healing. So the great advantage of this procedure is that after many, many years, you will have an aesthetic outcome in which you don't see any sign of graft exposure, but the thickness is the critical aspect in order to maintain stability of the long-term outcome. And when you compare the baseline situation with the 5 years outcome, and you compare, you can see that the increase in the soft tissue thickness is really limited to the area where it is critical to improve patient plaque control, toothbrushing technique, and also give the aesthetic appearance of the nice buccal profile of the cannon, but with no sign of any graft exposure. The graft is below, has increased the thickness, has allowed the patient to clean for many years, but you don't see because the patient don't want to see different color, different texture, and surface characteristics between the graft and the adjacent tooth. So this is how we manage now the treatment of gingival recession, and this is the consequence of a study which has been done in which graft of different height and of different thickness have been compared, and this tells you that you don't have to take big graft or thick graft in order to cover big gingival recession, but everything depends on the capability you have to keep your coronally advanced flap in position, and the graft is only used to give help to the flap to remain stable. So we don't achieve root coverage anymore with the connective tissue graft, we achieve root coverage only with the coronally advanced flap, and the graft is only used to help the flap when the recession is so deep, when the keratinized tissue remaining apical to the gingival recession is very close to zero, and so we have to improve the stability of the coronally advanced flap. So all clinical cases should be solved with a site-specific increase of the soft tissue thickness, where soft tissue thickness is critical. This is what is called minimally invasive aesthetic surgery. When you make this type of treatment that nobody show, because nobody show the profile of the teeth, this is not necessary. We don't need such an increase of the thickness. This is called pregnant gingiva. And we don't want to make any soft tissue pregnant, you know? Because it's completely useless. And you take a lot of thickness, a lot of tissue from the palate for something that is absolutely useless and painful. Can we avoid the use of connective tissue graft? It depends on the amount of keratinized tissue that we have in our flap. If we don't have any keratinized tissue remaining, like in the case of before, we are still obliged to use a connective tissue graft taken from the palate. But if we have a good amount of keratinized tissue, which is good in height but not enough in thickness, now we have the possibility to use what we call connective tissue substitute, or it's better to call them matrix. And this matrix that you have to see here, it's a matrix which is called mucoderm, and you will be available at the end of this year. It is a very promising and good matrix, because this is so capable to incorporate blood clot, so you will increase by itself the soft tissue thickness with time. What is the difference between the matrix and the connective tissue graft? It's about 4 months. In 4 months, the connective tissue coming from the maturation of the blood clot will become almost likely the connective tissue you take from the palate. But in the first 4 months, it's not. And so in these 4 months, you need a flap that is good enough because of the presence of keratinized tissue that does not shrink. As you have seen, the dimension of the graft is much more than the dimension of the graft. Not only 4 millimeters, but the matrix should be extended in order to cover 2 millimeters of bone, apical, and 1 millimeter more coronal than the cement enamel junction in order to have the tent effect of the matrix and separate the very, very thin alveolar mucosa from the root, that also in this case was very prominent. The vertical release incision are closed first, and then the last suture, which is again surgical, anatomical, palatal aspect. Now we turn the needle around the palatal cingulum, we go backally again below the contact point, and we make again a perforation, surgical, anatomical, and palatal aspect. And then, when we go back to the starting point, before closing the knot, the only knot that we make, we have to check that the keratinized tissue is covering for sure the matrix, because this is matrix, so blood clot. And if you leave the blood clot exposed, this is destroyed by the trauma and the oral bacteria. So it is mandatory to cover the matrix and to have a good flap to cover it with a good amount of keratinized tissue compared to the use of connective tissue graft, where you can also succeed in the complete absence of keratinized tissue. Just to remind the single steps, we measure the recession, 1 millimeter more, same distance from the papilla, 2 horizontal, 2 vertical lesion incision, 1 split thickness papilla on both sides, full thickness elevation of the flap in the middle, split thickness elevation in apical direction, which is made by 2 different incisions, 1 deep parallel to the bone, and the second superficial parallel to the soft tissue. This is something that we are going to repeat every single time when we're going to make surgery in all clinical situations, also implant, as you will see later. In only 14 days, that is the time of the suture removal, as you can see, the soft tissue margin, keratinized, it's in the right position, covering the enamel, but you don't see still any increase in the soft tissue thickness because we are in the maturation phase. This is not a connective tissue graft. It's not thick immediately. It takes time. After 3 months, you can start to see something that is completely different at the buccal aspect. That not only the keratinized tissue, but also the soft tissue apical to the keratinized tissue, which is alveolar mucosa, becomes as thick as it is the keratinized tissue, as it is completely separated from the root surface because of the increased soft tissue thickness, which was guaranteed by the presence of the matrix, which gave stability to the blood clot. So what is the difference between a connective tissue graft and a matrix? The connective tissue graft gives stability to the flap, because the flap is not stable itself because of the lack of keratinized tissue. The matrix gives stability to the blood clot, improve the thickness, the maturation, the stability of the blood clot, but absolutely need a flap that is stable by itself. And this depends on the presence of how much keratinized tissue do you start with. If you have less than 1 millimeters of keratinized tissue, you have to use a graft. If you have more than 1 millimeters of keratinized tissue, you can also use the matrix. In 1 year time, you see that the increase in the soft tissue thickness at the buccal aspect is exactly the same you should have with a connective tissue graft, but it's 1 year later. So during this time, the patient has to be much more careful in the toothbrushing technique, especially in the first 3 months. That is the time it takes the connective tissue to be mature and thick enough to allow a very, very effective toothbrushing technique by our patient. And now if you compare the thickness of the soft tissue apical to the keratinized tissue with the thickness of the soft tissue that is covering now the root, you can appreciate that despite the root was so buccally displaced, look here how thin it is, and look here now how thick it is. You can see that this can really work, but this worked because we started with a baseline amount of keratinized tissue which gave stability to our flap itself. So this is the same aspect with the profile that allows you to appreciate much better. And this is 5 years outcome in which you can see again the increase in the thickness together with the coverage. But remember that the coverage does not depend on the presence of the matrix, but depends on the capability of the coronally advanced flap to maintain stable the keratinized tissue in coronal position. Can we apply the same surgical procedure in the lower jaw? And especially in the most difficult areas of the patient mouth, that is the lower incisors, when you have deep gingival recession. I mean, I don't know what happened here. You see, this is such a deep gingival recession that once the recession reaches the fornix, it cannot get further in apical direction because there is the lip that is completely horizontal oriented with respect to the most apical